Hey everyone, and welcome back to MedSnap RX. So today for our question, we have a 45-year-old patient with right upper quadrant pain, and this is a step 2 CK style question vignette. And we're going to go over some of the diagnostic methods that you're going to encounter on test day and inside your clinical practice as well. So let's get started. Alright, so we have a 45-year-old woman. She's coming to the emergency department with a 2-day history of right upper quadrant pain that's been worse after eating some fatty meals. She says that the pain is constant, it's a dull ache, and it sometimes has some sharp exacerbations. It's about a 7 out of 10 severity. She also reports some nausea and one episode of vomiting earlier in the day. She hasn't had any fever, chills, or any changes in her bowel habits, but she said that her urine might appear a little bit darker than usual, and her stools are also pale. She has no history of alcohol use, recent trauma, or travel. She is obese. She does have type 2 diabetes, but she is taking metformin for it. She hasn't had any sort of abdominal surgeries either. On her physical examination, her temperature is 37.2 degrees Celsius. Her heart rate is 88 beats per minute, blood pressure is 130/80, and her respiratory rate is 16. She does appear uncomfortable though whenever you're looking at her, and she has some tenderness to palpitation in the right upper quadrant and a positive Murphy sign. There's no rebound tenderness or guarding. Whenever you look at her sclera, they're mildly icteric, and her skin shows no jaundice. And here's some laboratory results for you as well. So, which of the following is the most appropriate next step in the diagnostic workup of this patient? So read through the options, and I'll give you a couple seconds to pause, and then we'll go through them. Alright, so the correct answer was A. You're going to want to order an abdominal ultrasound. So let's go through the question stem and figure out what was pointing us to this finding. Alright, so we have a 2-day history of right upper quadrant pain. So what lives in our right upper quadrant? That's going to be your liver and your gallbladder. And anytime you're thinking of right upper quadrant pain, for the sake of these exams, start thinking gallbladder. It's worse after eating fatty meals, and it's a constant dull ache with occasional, and here is the key test point, sharp exacerbations. That is essentially, in another way, saying colicky pain. You should really be thinking a gallbladder issue right now, maybe some gallstones. She's having some nausea, and she vomited as well, so she's in a lot of pain. She's not feeling well. Her urine's appearing dark, so she's having some of that bilirubin. It's going into her urine, and her stools are pale, so maybe she has some sort of obstruction. And then she has no history of alcohol use, trauma, or travel. That's kind of just stating that it's probably not like a liver fluke. It's probably not that she's having alcoholic cirrhosis or that she's had any recent acute trauma. She's obese, which is a risk factor. She's, if you ever hear like the moniker fat fertile 40, especially within a woman, and female is the other F. That is essentially what you need to be looking at for these question stems for potentially a gallstone. And looking through all these risk factors, whenever we get to our physical exam, we see she's very uncomfortable and she's having tenderness and a positive Murphy sign. So the next time you're on inpatient wards or you have a patient with some gallbladder pathology, if you press on their right upper quadrant, you ask them to inspire and you keep pressing your hand. Whenever they go ahead and push back, whenever their cavity fills back up with air, that's going to create a lot of uncomfortable pressure for them on that gallbladder, and it's going to cause them to rebound on you, and they're going to try to move out the way, or they might even let out a yelp. That is a positive Murphy sign, and whenever you hear that in a test question, that is pointing you towards a gallbladder pathology, mainly a gallstone. So whenever we look at her lab values, her white blood cell count's elevated, so she's probably got some sort of illness within that gallbladder. Her total bilirubin, her direct bilirubin, and her ALP, importantly, are all elevated. Liver enzymes can be elevated as well, but ALP is extremely diagnostic for this condition. It's very sensitive. Now, it's not necessarily specific because you could be thinking about a bone pathology. However, if you see ALP in a question with right upper quadrant pain, I want you to be thinking of the gallbladder. Okay, so if we go back and we read our question, it's what is the most appropriate next step? So it's not saying which of these are correct. What is the most appropriate next step? So in the next slide, we're going to go ahead and break down each of these answer choices and why they're right and why they're wrong. All right, so let's talk about the answer choices. So A, C, and D are part of your normal workup for a gallstone. You're going to want to start with an ultrasound. It's quick, it's easy. It can show you some gallbladder thickening. You might even be able to visualize the stone. but it'll help clue you in onto what your patient's pathology really is within that right upper quadrant. You might even get a sonographic Mercy sign too, which is almost pushes you a little bit over for that differential as well. But you're not invasive for the patient. You're not doing an endoscope. You're not injecting a radionucleotide. And something you can do at bedside that's going to help rule in or rule out your differential. This is always the first line whenever you suspect a gallbladder disease. However, if you're having trouble, then if they say in a question stem or in real life, if you hear, well, my ultrasound was equivocal, it didn't rule in or rule out, you can get a HIDA scan, and this is a radionucleotide that will check for filling of the gallbladder. And if you have essentially a blockage of that cystic duct, you're not going to fill in the gallbladder, and you're going to kind of get clued in at that point too. Hey, something's probably stopping it. We need to go ahead and investigate further, and you probably want to go ahead and actually visualize them. So at this point, if you're like, okay, ultrasound was equivocal, we did a HIDA scan, it showed that it's not filling in the gallbladder, something is blocking, then you can use an endoscope. An endoscope, an ERCP, what they actually do is it's using radiography. You're going to go ahead and put an endoscope down the throat. They weave through the stomach and they get right in front of the gallbladder. So you actually go into the duodenum. And what they're seeing is it's both diagnostic and therapeutic. So they can actually see and directly visualize an obstruction. So, okay, right here, we need to get this stone out. And they can actually remove a stone too, which is pretty awesome. However, consider everything I just said. Is that more invasive than an ultrasound? Yes. And it probably will lead to the second step in management, but you would still be able to diagnose from either step. The question didn't say, what is the end all be all for this? The question said, what's the most appropriate next step? And even though this is correct in some sort of sense, it's not the most appropriate. However, if we did need to get this stone out, this would probably be our choice. And then order viral hepatitis serologies and the CT scan. So I kind of threw these in there as just like quote unquote liver pathologies. We're probably not thinking hepatitis in the way that this patient presented. This would be more of a chronic course, not that she's having colicky pain with fatty foods. In a CT scan, you can visualize some stones. However, you won't be able to see the radiolucent stones. Remember that. That's more of a step one thing, but it might pop up again. And we're exposing our patient to ionizing radiation. In a HIDA scan, we're using a nuclear medicine. In ERCP, we're sticking a scope down their throat. So you really have to think about this in terms of who would want these really invasive tests done to them whenever you can just use an ultrasound. And quite honestly, that's an amazing first step in helping rule in or rule out your diagnosis. So you, as a physician, you need to have enough confidence within yourself to say, you know what, my clinical exam skills are where they need to be, and I can use this test to rule it in. And this is kind of what this question's testing. It's seeing, do you know when to stop? Or are you a little bit scared and you're like, okay, well, let's do the ERCP so we can see it and we can get rid of it. I hope that makes a lot of sense. If you have any questions, feel free to put them in the comments. This is a very confusing topic, so I'm going to put a little bit more questions on this as well. And this is kind of brand new in the series. This is question 2, but I will be making a lecture series as well, where I'll go through some of these tests. I'll put some pictures up, show how they actually work. We'll talk about the pathophys in a little bit more detail and the actual therapeutic means. So whenever you're answering these questions on a test, you're not just kind of shooting in the dark, trying to remember like silly mnemonics between HIDA and ERCP. You actually know what they are, and you'll know whenever to order them. All right, so I hope this was helpful. And as always, happy studying.